For those new to us, I will introduce Dr. Maldonado and highlight some of her many achievements. She has received her MD degree from Stanford School of Medicine. She then completed residency in pediatrics and fellowship in infectious diseases at Johns Hopkins University in Baltimore. She then continued her career at Stanford as faculty from 1988, where she is currently professor of pediatrics and professor in Department of Health of Research and Policy. Dr. Maldonado has served as section chief of pediatric infectious diseases from 2008 and is currently also a senior associate dean for faculty development and diversity from 2014, and in 2020 was awarded endowed professorship in global health and infectious diseases. I do wish to mention that we are proud that this year Dr. Maldonado has received an American Academy of Pediatrics President's Award for Outstanding Service. In addition, Dr. Maldonado's academic contributions include over 170 peer-reviewed publications, numerous invited lectures, conference presentations, guidelines development, and book chapters. With that, I will ask Dr. Maldonado to proceed with Grand Rounds. It is my honor to welcome you today. Thank you.
Well, thank you so much for that introduction. And I am going to go ahead and share my screen. It's a pleasure to be here. And as you heard, we'll be talking about COVID next week. I am not going to talk about that today at all. So let's stay tuned for next week. And I want to give a Red Book vaccine update today. I'm also the chair of the Committee on Infectious Diseases for the American Academy of Pediatrics, commonly known as the Red Book Committee. And here's I have millions of these at home because we've done 5 Red Books during the time that I've been on the committee. Once you join, you basically have tenure for the committee, but I'm actually sadly rotating off the committee this year. I'll be stepping down, and Sean O'Leary from University of Colorado will be taking over as chair. So it's been a wonderful opportunity to get to know my colleagues and help with crafting vaccine policy and infectious disease policy for the nation's 67,000 AAP members. So here are my disclosures for you to see. And our objectives today, I'm going to try to touch on, there are many topics that we could discuss, but these are the 4 that I thought would be the most helpful. We're going to go over flu season. I have no predictions for next year, but I'll talk about what we've seen in the last few years. Talk about general immunization status of children, the impact of upcoming PCV15 and 20 vaccines in the pediatric population, and then finally, some really high-level information about upcoming potential therapeutics for and preventative vaccines for pediatric and other RSV disease. So if you ever want to see the vaccine schedule, it's at the CDC website here, and there are some really nice resources there to download these forms in color or black and white and be able to put them up in offices. And the ACIP really strives to, and by the way, I should give a shout out to my colleague and division member, Dr. Grace Lee, for chairing the ACIP. She's been the chair now for almost a year and has been a member for some time. And she has done a tremendous job of leading the ACIP during these really historic times. But the ACIP really does try to provide a really easy to read format. I know that the schedules can be a little complicated, but up on the upper left is the immunization schedule overall, an at a glance view of all of the different vaccines, color coded for age and an indication. And at the bottom right, I really like this particular edition. It is an immunization schedule by medical indication. So you can see that there's one for pregnancy and for people with underlying conditions, et cetera. So these 2 schedules can make it really easy for people to understand exactly what vaccines need to be given for, especially for specific medical underlying conditions. And the new ACIP immunization schedule, the American Academy of Pediatrics generally always endorses it. Sometimes we have some nuanced differences, especially around things like HPV vaccine, but we generally harmonize. And this year's Recommendations just include some updates on the flu vaccine. I think there's nothing earth-shattering there. Basically just new serotypes available for this coming year. There's also the addition of the dengue vaccine primarily for Puerto Rico, Guam, and a few areas where dengue is endemic, and they're complicated, so I won't have time to talk about them here. They're not in use in the mainland US, so I would encourage people to take a look if there are individuals who are planning to live in these areas. And then, of course, there are numerous recommendations for COVID-19 vaccines, and then a number of minor changes around several different vaccine types there listed at the bottom, and the links are at the bottom here of my slide. So let's start with influenza. Again, this is a perennial disease, and in many ways, the precursor to what we're seeing now with COVID. So let me just give you the highlights for this season. And this was a mild season, but even in a mild season, we have had 5.3 million flu illnesses, over 50,000 hospitalizations, and over 3,000 deaths from influenza. The influenza activity is not gone. It is starting to drop, but it is by no means over this year, which is a little unusual, as we know, for flu season, but we understand, you'll see in a bit, flu activity has not been normal in the last couple of years. And it is continuing to increase in some areas of the country. Stanford is part of a CDC surveillance project for flu and COVID, and in the New York area in particular is seeing actually very high levels of influenza still. We also want to make a point of having people recognize that there is human detection of avian flu H5 in the US. Now, there's only been one case, but this is a virus with extremely high mortality on the order of 30% or more. Fortunately, there's only been one case and the person was asymptomatic. So we are keeping an eye on this avian flu. And then the overall cumulative hospitalization rates, you'll see in a bit, they're higher than for last year, but they're lower than previous seasons. And so far, 23 pediatric deaths have been reported from flu. So if you look historically at the annual burden of influenza, we haven't had really a great update here for a couple of years, because fortunately for us, we haven't had lots and lots of cases. But even as you heard before, generally since 2010, so over the last 12 years or so, we see between 9 and almost 50 million cases. As I mentioned, this year, there were only about 5.25 million cases. So on the lower end, and hospitalizations, you see there generally about 140 to almost 1 million hospitalizations. This year, again, about 50 million. With about 3,200 deaths, you see where the deaths generally can go up to almost 80,000. And here you see over time the number of deaths, hospitalizations, and illnesses by year. And it really does evolve as the virus evolves and our immunity to the viruses evolve. So it's really not predictable. And this is one of the major reasons why we really emphasize vaccination for everybody 6 months of age and older, because we just don't know what's going to happen per season. Now, these are the data, again, broken down a little bit more through April of 2020, really the last time we had sufficient cases to really lay this out. And you can see, again, just from in a 1-year period, even during just before the pandemic, we were seeing millions of cases, millions of medical visits, hundreds of thousands of hospitalizations, and deaths that, again, were far outstripped what we're seeing this year. And we are concerned that as time goes along, those numbers will continue to go up as the COVID pandemic starts to slow down. People go out and about and start to walk around unmasked in public spaces. So we want to make sure everyone's vaccinated. Now, this is a slide that is getting a little more complicated for me to put together, because I want to give you some historical perspective. So in the top right, we're talking about influenza positive samples from general laboratories around the country where we do surveillance. And you can see this is a normal year up in 2019, 2020, just before the pandemic. And you can see that there was basically an even split between flu A and flu B cases, although the cadence was different. Flu B led off that year and then flu A followed. And then you see what happened on the upper right in 2020 to 2021. We had almost no influenza, but it was primarily B. And then this year, remember, note the y-axis. So you're seeing at least, almost a 5-fold reduction still, even from pre-pandemic levels, but higher than last year. And almost all of this is flu A. It's mostly H3N2. And you notice that while it's coming down, we are in April and we still haven't seen it drop to the levels that we're normally used to seeing at this time of the year. So still a fair amount of flu activity. If you look at the actual number of cases from last year compared to this year, last year we had a record low number of almost 1,800 cases in the box there that were reported out of almost 1 million tests done. Whereas this year, with over 2 million tests done, we've seen more like 85,000 positive tests. So we are starting to see a real uptick in influenza in the US, again, mostly H3N2. I really like to see this slide here on the left because it gives us a historical picture of what happens over time and how unpredictable influenza rates can be. So these are influenza over the calendar year by a year. And this gray line is important because this was the 2009 pandemic, H1N1 pandemic, and that was a brand new H1N1 strain. And that is now the parent strain for all H1N1 that we've seen since 2009. And you see that it peaked out in April, and I actually remember the date that it was reported. And so it really peaked in April of 2009 and really continued to drop off over the rest of that year. So we didn't really have a season at the end of 2010 and 11, 2009-10, because that year was quiescent given the high peak early in the year. But you see over the next several years, cases have started to rise. And then here we have in the pink line, we have 2020-21, which really didn't even reach epidemic levels, which is this dashed line. And now this year in the red triangles, we see that we are starting to get back into a normal cadence. Sorry about that. On the right, you see the number of ILI or influenza-like illnesses by age group. And you can see that the 0 to 4-year-olds in both 2020, 2019 and 2021 seasons was very high. So here you see early on, this is beginning of the year, ILI for young children, all 0 to 4 leads the way in terms of number of reported cases and tests, and really starting to go up at the end of 2021. Here's the rest of 2021, October 2021 to April of this year, 2022. You see that there is a mild increase more than last year, but 0 to 4-year-olds still lead the way in the number of cases. And then you see here over the years, laboratory confirmed hospitalizations, looking at 2015, 2016, 17, 18, 19. So generally going up, and you see that 2020 and 2021, very low cases. Interestingly enough, 2011 was low, and that was the year pretty much immediately following the 2009 pandemic. So this may reflect, at least for 2011, a large degree of population immunity after a brand new pandemic virus was introduced in 2009. And here you see on the left, pneumococcal, pneumonia, influenza, and COVID-19 mortality. So aggregated, not separated out, as of April 28th of this year. So you see, this is what we call the epidemic threshold. This is the number of cases over which we see, we call this an increase or an epidemic, and that this happens every year. And you can see here that these are the number of deaths in red due to pneumonia, influenza, and COVID-19 aggregated. So even though the number of influenza deaths was low in the yellow, you see the yellow down at the bottom here, you see that the aggregate of respiratory deaths was quite staggering for that year. And here we see 2018, 19, 20, and 21 deaths in children. And as we said, there were 23 deaths so far this year. Last year, there were only 2 deaths in children. I think one death in children in a child from influenza. But we're starting to see it go up. And my sense is that the numbers will continue to rise as we saw what happened after the pandemic flu in 2009. And then again, this is just another way of looking at what happened before and after the 2009 pandemic to give us a sense of what might happen after COVID. So you see here, all of these numbers, most of these cases are trends began in 2002 and work all their way up to 2009 in the gray. So you see most of them are normal years. And then 2011 is the year immediately following the pandemic of 2009. You see again, very low rates. So we did see that. And it turns out that 2 years later, we saw what we're seeing now, which is flu just started to come back. So it's not going anywhere. And we suspect that it will be back this coming fall. And then finally, this is an older slide from April 2020. We didn't have updates for the last couple of years because we didn't have enough cases yet. But the issue to remember here is underlying medical conditions are associated with influenza, hospitalizations, and mortality in children and adults. And in the green is children, blue is adults. And you can see that there are a number of underlying conditions such as asthma, cardiovascular disease, lung disease, etc. But the real issue here that I like to point out is obviously those are important, but 50% of children had no underlying conditions who were hospitalized. So we really have, more than adults, we really have to be aware that children should be vaccinated because we don't know really there are risk factors for half of the kids who get flu and are hospitalized. So let's move on. And I want to talk about general childhood and catch-up immunization schedules during the COVID era, because this has been a major impact. As we know, COVID has impacted just about every facet of our lives, and usually in a negative way. But here is one thing that is really concerning. And you can see that recently, the Measles and Rubella Initiative, of which I work with them indirectly, it's a global organization that really is trying to eliminate or eradicate measles and rubella, much like polio. These are vaccine preventable diseases that we can actually eradicate from the face of the earth. We haven't gotten there yet, but we're getting closer. You see that the UNICEF and the World Health Organization warn of a perfect storm of conditions for measles outbreaks affecting children. Reported worldwide cases increased by 79% in the first 2 months of 2022 compared to 2021. And we are facing, as they said, a perfect storm. Why is that? Well, worldwide measles cases increased, as I mentioned there. About 17,000 cases occurred just in the beginning of this year, January and February, compared to 9,000 cases for a comparable period in 2021. In between April of 2021 and this year, there were 21 large and very disruptive global measles outbreaks. The most disruptive were in areas where vaccination has been difficult. Although it has been poor all around the world, it's been particularly a problem in areas such as Somalia, Yemen, Afghanistan, Nigeria, and Ethiopia. And as of April 1st this year, 57 vaccine preventable disease campaigns, that is national immunization days where we go out and vaccinate children, all children in different populations around the world. So 57 campaigns in 43 countries that were scheduled at the beginning of the pandemic are still postponed, impacting 200 million children, mostly children. And of these 19 postponed campaigns, of these 19 of the 57 campaigns that were postponed were measles campaigns. So measles, remember, is a very important cause of death in children around the world, even though that doesn't appear in the US. It is one of the top causes of infectious disease deaths in the world. So we are concerned about this reduction in immunization. Now, if we look at the US, we know that many school-aged children missed their recommended vaccines over the last few years because of disruptions. And I'll show you some data, but this is especially concerning for measles vaccine and vaccines routinely recommended at 11 to 12. So overall, the under 2-year-olds actually did manage to catch up reasonably well, but the 11 to 12-year-olds did not. and schools may not have been able to focus on compliance during the past school years, given all the other disruptions. And we really need to make sure that children are caught up. Now, this is an early slide from the pandemic from January through April of 2020. And these are all non-influenza vaccines for children. And you can see the measles containing doses in the dotted line versus all the other non-influenza vaccines. And you see what happened there in March after the lockdown. The numbers of vaccinations plummeted as we had trouble really accommodating children in outpatient visits because of the lockdown and the surge of COVID cases. So some of these we saw no gains after this period, and I'll show you those data as well. Now, there's some good news here. If you look at a comparison of vaccine for children provider orders, so these are primarily public provider data, you see that in the orange is all vaccines, and these are for FY22, and in the blue these are all vaccines in FY19. And you can see that overall we are starting to catch up. So the orange bars are starting to match the blue bars. That is, public orders for vaccines, for VFC vaccines, are starting to get back to normal. But overall, our cumulative variance, that is the number of missing doses, is on the order of 1.5 million doses of all of these vaccines for children who just have not gotten their catch up primarily, or haven't come in since the pandemic. If you look at measles containing vaccines alone, we're doing pretty well. We only have a cumulative deficit of just a little over 5,000 doses. So that's really helpful to see. If you look at HPV, again, we were seeing problems, especially in the 11 to 12-year-olds. And you see that we are starting to catch up again with orders. Now, remember, this doesn't mean that the kids who didn't get vaccinated during the pandemic have been vaccinated. This is just regular orders for ongoing kids visits. So that means that whoever didn't make it during the lockdown year of 2020 may not actually be vaccinated at this point. And this is a deficit of about 150,000 doses. And if you look here at a comparison of provider orders for all non-flu vaccines at the top and measles containing vaccines at the bottom, you can see, I mean, side by side what we've been looking at. So again, the numbers have been hovering around for measles containing vaccines around where we were before the pandemic, but not so for all other non-flu vaccines. And then if you want to break them down by type of vaccine, these are non-flu vaccines, you see that there's a differential. So we're seeing in FY20, we saw the biggest deficit in hepatitis A, measles vaccines, HPV, and Tdap, whereas in this year now we are seeing less variance. So really, the biggest variance is about a 10% reduction in HPV vaccines. Otherwise, it looks like we are doing a better job. Now, the overall non-flu cumulative change for the 2-year period is about 10% decrease, or 14 million doses. The bottom line is we need to get our kids caught up. And we know that there are also health, racial, and ethnic disparities. So here you see the overall vaccine rates for 2019, 20, and 21 seasons in red, gray, and buff colored. And you see the numbers are low, dropping a bit overall. Hopefully those will rebound, but the numbers are particularly impacting the Black non-Hispanic population more than any of the other populations we see on this slide. And then if you look at where people are missing vaccines overall, we see that overall 97% of these orders are open, but the median change is about a 14% reduction. Medical practices in general are doing well, but you see understandably that local health departments and federally qualified health centers have really borne the biggest impact because they were dealing with the COVID-19 testing and vaccination strategy. So really had less resources and personnel and bandwidth to be able to keep up with general vaccinations. And you see down at the bottom, other clinics as well suffered. And these were school-based centers, hospital, tribal health, and correctional facilities. So overall, unfortunately, the most vulnerable actually suffered the most disparities in normal vaccinations. So what are recommendations? Well, of course, our healthcare systems and providers should identify families whose children have missed doses and really make an effort to try to bring them back. Prompt clinicians to deliver vaccines when they are due or overdue, and let families know what precautions are in place for safe delivery of in-person services. And communication, of course, is critical. I'll show you a few slides in a bit about the communication campaign from the CDC at the national level. So here are some efforts starting. The goal here was to encourage parents, especially those with socioeconomic disparities, to prioritize catch-up or routine vaccinations by increasing self-efficacy and perceived benefits. The target audiences are parents with children 0 to 6, with an emphasis on 3 to 6-year-olds who missed or delayed visits, because as we know, we are already seeing the younger children coming in on a routine basis in better numbers. So the campaigns are really focused on spring to fall of 2021, fall to winter of 2021, and now spring of 2022. And I'll show you what those are. So phase 1, from spring to fall of 2021, new assets were developed to include social media across platforms. Communication efforts include paid media, social, digital, other media in English and Spanish, and partner outreach, in particular with our immunization coalitions. And you see some of the materials here that are available at the CDC website. If anybody's interested, these are widely available. Our public health departments have them as well. Phase 2 was really looking at informing communications by research, formative research in particular, with virtual focus groups to understand what were the obstacles for parents delaying their children and what would get them back, and what kinds of creative concepts could be developed to message. And so based on this, we saw this campaign roll out through CDC called Let's Play Catch Up. And again, paid media, social, digital, other media, and partner outreach going on. By the way, the American Academy of Pediatrics also had their Take Your Best Shot campaign as well during this period of time, trying to get the word out to pediatricians and having the word go from pediatricians to families. So these were efforts in conjunction with the AAP. And then finally, we are looking at refreshed outreach of elevating awareness. This is this spring of 2022. Again, still messaging even beyond the Let's Play Catch Up in multiple languages, ongoing paid media, groceries, TV and Spotify, social and digital opportunities, partner outreach. And we had a fairly successful National Infant Immunization Week a couple of weeks ago, summer camp, back to school messaging, and again, additional partnership with big social media giants, as you see down at the bottom there. So we know that this is a continuing effort, and we really encourage all of you, every single one of you, if you have patients, regardless of your specialty, please make sure you emphasize to the families that we really need to catch up. These are opportunities to prevent vaccine-preventable diseases and deaths. In the case of HPV, for example, these are problems that will not surface for 10, 20 years or more. And so we really need to get those kids caught up. Now, I'm going to talk about PCV15 and PCV20 in children. And I just want to go over just some basics about this. So we know that PCV13 and 13 was licensed. PCV13 was licensed in 2010 and had tremendous impact. PCV7 had tremendous impact. PCV13 in 2010 had additional important impact on pneumococcal disease prevalence in children in the United States and around the world. Now, in July of 2021, PCV15 was approved by the FDA for use, and the ACIP reviewed those recommendations in October of 2021 for adults. So you can look at the adult recommendations, and basically I'll just say that PCV15 or 20 are both recommended, no preference, for adults 65 and older and for other younger individuals who have underlying conditions. PCV20 would be standalone in that situation. PCV15 would be given with a follow-up dose of PPSV23 or the pneumococcal non-conjugate 23-valent vaccine. That's for adults. Now, we know that the FDA is also, the CDC, ACIP is working on recommendations for kids, and I'll show you some of those preliminary data that have come from the open access ACIP meetings, because this will be coming soon. And we think that there will be recommendations for PCV15 in the coming months, and for PCV20 for children by 2023. So this is really helpful to start to understand what might be happening in the next year or so. And so what we see here are the 13 serotypes in yellow that are covered by PCV13, the additional 2, which are 22F and 33F, that are in PCV15, but are not in PCV13. And then the additional 5 on top of that, that are available in PCV20. And then finally, the additional 4 serotypes that are in the PPSV23 vaccine, the pneumococcal non-conjugate 23-valent vaccine. So again, just to set a level playing field, you have additional serotypes now over time, and we're going to see what the impact of these, and the CDC ACIP working groups have not made a final decision, but I'll show you some of the preliminary data here. And then just for the purposes of analysis, PCV6, well, we'll show you to you in a bit. There is some cross-reactivity among 2 vaccine types. So here again is the recommendation for people 19 years of age or older that we already have recommended from October, as I mentioned earlier, and I'm sorry, from January of this year. And you see that for people 19 to 64 who are healthy, there are no recommendations. If there is underlying medical conditions or alcoholism for 19 to 64-year-olds, 1 dose of PCV20 or a dose of PCV15 with a dose of PPSV23 1 year later is recommended. That is, PCV20 is standalone. And if you elect to give PCV15, it's recommended to follow it by a dose of PPSV23 a year later. Similarly, for all people over age of 65, as well as those with underlying conditions, this is a similar recommendation. So it's reasonably straightforward, I think, when you look at it this way. Now, in terms of price, if you look at the projected prices for not only PCV13, those are existing prices, but for 15 and 20 and the existing prices for PPSV23, you see that the PPSV23 obviously is cheaper. It's not a conjugate vaccine, but the others are reasonably comparable, and administration costs are listed here as well. Now, these are policy questions proposed by the ACIP pneumococcal vaccine working group that are coming up for consideration in the coming months. And they are, should PCV15 be routinely recommended for U.S. children less than 2 years as an option for pneumococcal conjugate vaccination according to currently recommended dosing and schedule? That is, should it be PCV13 or 15, either one? And that's the consideration that's being made right now. That decision has not been made yet. And then finally, should PCV15 be recommended for U.S. children with underlying conditions who are 2 to 18 years of age as an option as well? And so fortunately, there is no consideration in changing the schedule, the number of doses or schedule. As we know, these are all 3+1. That is, they're given at 2, 4, 6, and 12 to 15 months of age. At one point several years ago, there was a consideration to give the pneumococcal vaccines at a 2+1 schedule, which would have just been a 2 and 4 month, and then the 12 to 15 month dose. There were a lot of discussions with AAP. AAP was not in support of this, absolutely, because we do see some drop off in that third dose. So essentially, if you had a 2+1 dose, we worried that children might not be getting their full immunization schedules, immunizations. And there was, we thought, an unacceptable number of breakthrough cases if you drop from a 3+1 schedule to a 2+1 schedule. So that is not on the table for the foreseeable future. And we don't have any considerations yet for the PCV20 because that has not been really put on the table yet. We don't expect to see that till next year sometime. So here's a slide. Again, it's a little complicated, but I think when you lay it out this way, it's a much easier thing to look at. This is how we look at current recommendations for PCV13 for children with underlying conditions. And you see here, they're recommended for a number of underlying conditions. PPSV23 is also recommended for a number of underlying conditions with revaccination 5 years after the first dose for selected conditions such as functional or anatomic asplenia or immunocompromised conditions. Now, here, what is the science and what are the data showing the invasive pneumococcal disease rates? And this is a true, this is what really drives me to really think that vaccines are critical, because look at these data. I mean, if you look at any vaccine preventable intervention, you see slides like this, where here's the intervention in 2010 of PCV13. This was after PCV7, earlier in the early 2000s. And you see that immediately after introduction, you see a drastic reduction of all invasive pneumococcal disease in kids under 5, with the vast majority of reductions, 89% reduction in the serotype specific vaccine serotype disease, and a stable but mild decline of 27% in non-PCV13 disease. Now, a 6C is added into the PCV13 because it has cross-reactivity with the serotype 6A, which is in the PCV13 vaccine. So you can see tremendous progress there. And by the way, this introduction also reduced, there was community herd immunity impacts, indirect effects, we call them, on people 65 and older. So with the introduction of the 2010 of the PCV13, we saw dramatic reductions in disease in 65-year-olds and older that actually did not change even when vaccines were recommended for adults. So there's a tremendous degree of community impact as well. Now, if you look at incidence rates of invasive pneumococcal disease among children under 5 over an 8-year period by the PCV13 plus 6C serotypes, you can see here those reductions that we talked about. And at the end, you see that of the remaining disease incidence, which is just a little over 1.5 per 100,000 children, you see that the vast majority are attributed to 4 serotypes, 003, 19F, 19A, and 6C. And these are types that are not in the current PCV13 vaccine. So these are what essentially is left. There are non-vaccine serotypes in there, but very few of those. You can see that the vast majority are those 4 serotypes. Put another way, if we look at incidence rates by type of vaccine, if you look at the PCV13 vaccine in blue, the PCV15 in buff colored, and gray is PCV20, and you look at the serotypes, the additional serotypes contained in each of those, and look at the impact of invasive disease, not because these vaccines have been put into place, the 15 or 20, but if you look at the serotypes that are in there and how much disease they account for right now, they are equivalent. So the number of PCV13, 15, and 20 serotypes account for about a third each of the current cases of disease. So you could see that theoretically, if you added the 15 and 20, there might be a reduction, a potential reduction in some of those orange and gray bars there. And again, look at the y-axis here. This is 5 to 18-year-olds. The previous slide was 5-year-olds, and the axis there is 9 cases per 100,000. Here we're talking about 5 to 18-year-olds, and This is 1.4 or so cases per 100,000, so fully almost a 10-fold reduction in cases in those age groups overall. That's just the natural epidemiology. But even here, you see that there is about an equal proportion of cases of invasive disease attributed to each of the vaccine serotypes. So we would imagine that there could be an impact, an equivalent impact of each of these vaccines on reduction of IPD to even lower levels. Now, if you look at it in a stacked bar, you see here for children under 5 versus 5 to 18-year-olds, you see in the dark blue the number of cases of IPD for 2018 to 2019 before the pandemic. Really, almost the majority of cases for under 5s are in the non-vaccine types, and in the 5 to 18-year-olds, about 32% of all cases are from the non-vaccine types. And you see the additional impact of PCV15 serotypes, the 2 that are not in the 13, and the impact there is about equivalent in both age groups. And then you see the impact of potential addition of PCV20. So there is a potential to reduce even further, but we know that there's still a large impact of existing pneumococcal PCV13 serotypes plus non-vaccine types as well. Now, when you look at acute otitis media for a 4-year period, you can see that we are seeing an impact of PCV13 there at about 8 to 9% from NP swabs or middle ear fluid taps. And then you look at 19F and 19A and 3, serotype 3. So those all have additional accumulative effects. None of these are in the additional vaccine serotypes. And if you look at the 6-15 PCV15 serotypes, the 2 extra serotypes, they do account for between 6 and 8% of middle ear fluid or NP swab disease. And all of their serotypes really make up the vast majority of additional acute otitis media. This is a slide, just briefly, I know it's a busy slide. This is from the data that was used to provide licensure by the FDA of the PCV15 vaccine. And you see that basically the seroconversion data demonstrate that the vaccine is non-inferior to PCV13 for 12 of the 13 shared serotypes. There is a reduction in serotype 3, but it does not appear to be substantial, and it was approved based on these data. The seroconversion rates were very good. And then if you look at the adverse effects of PCV15, they are comparable between the groups of PCV13 versus PCV15. There is a little bit of increased fevers, but not substantially so in the toddler 4th dose group. And then overall, when you look at the summary of the ACIP work group, they are looking at the benefits harm. They call this the evidence to recommendation. They use whether it's a public health problem, benefits, harms, is the benefit greater than the harm here? They feel that it so far favors intervention. The overall certainty of effectiveness and safety seem to be somewhat reasonable. So they are still continuing to look at whether this is a vaccine that would be reasonable to approve, and there will be additional meetings in the coming months to finalize this evidence to recommendation and to come up with a vote. And I think the big question here is going to be, and AAP is going to be asked to weigh into this as well briefly, and we will certainly make our own determination. But the question is, should PCV13 and 15 stand side by side? No preference, or should one be preferred over the other? And at this point, there is not a decision that is being made. But in general, many vaccines generally stand side by side with no preference for one over another. So there will be some decisions to be made in the coming months. I wanted to end with RSV. And here's an introduction from the ACIP meeting. Dr. Sarah Long, a close friend and colleague, also worked on the Red Book for many years, and at St. Christopher's and Drexel School of Medicine. At the meeting in January, looking at a new reactivation because RSV working group had been deactivated for some time. It had been in place in hopes for an RSV vaccine, and those hopes had dimmed for some years, but now we are looking at more potential. I'm not going to spend a lot of time talking about the vaccines because they're under clinical trials now, but there is going to be some high-level discussion here, which might be exciting for us because there are some potential interventions. So the work group really wanted to get back together because we know that RSV is a major cause of lower respiratory illness, especially among infants, young infants and children, and those older people with chronic medical conditions. And there are RS vaccines and monoclonal antibody development, which has progressed in the past decade with over 40 vaccine candidates and monoclonal antibodies that are showing promise. And the target population include infants and young children, pregnant women, and older adults. So the work group will be considering use of RSV vaccines and monoclonal therapies for children under 18, looking at the epidemiology and burden of RSV in children and pregnant women, efficacy, immunogenicity, safety, and cost effectiveness of these vaccines and monoclonals, and further areas of research that might be needed. So in the coming months, there will be a review of the safety and efficacy of the vaccines and the monoclonals, seasonality data, which is, as you know, all over the place right now, but when we start to stabilize, what is the seasonality data for timing of these vaccines, cost effectiveness? The data will be presented to the AAP, and as you saw earlier, the evidence to recommendation will be developed with a vote expected sometime in 2023. So we are getting closer. What I wanted to show you here is that there are a number of RSV vaccine products. There are 4 major vaccines. Here at Stanford, I'm proud to say that in collaboration with my colleague, Dr. Natalie Aziz in the Department of OB/GYN, she and her team, and we have been working on a Pfizer maternal RSV vaccine, primarily to see if it protects not only the mother, but the newborn infant with passive antibodies. So there is a Pfizer maternal vaccine that we're working on here. There is a Pfizer elderly patient vaccine as well. And then there are 2 vaccines from GSK looking at maternal and elderly populations as well. And then AstraZeneca and Merck are working on anti-F antibody monoclonals. These are thought to provide neutralizing protection against disease. So I want to just end with some last data around one monoclonal, which is showing really good promise, just not very many studies yet, but there is some promise here. And it's called Nirsevimab. And this is prevention of RSV in healthy late preterm and term infants. And this article really demonstrates that in a study looking at children 35 weeks of gestational age or greater entering the first chronological age or greater entering the first RSV season with a single dose prior to the onset of the season in a 2-to-1 randomization, looked at medically attended RSV and hospitalization. No safety concerns were identified. And for medically attended RSV, the intervention demonstrated almost 75% efficacy, and for hospitalization, about 62% efficacy. You can see here the demographics of the population in that New England Journal study. So when you looked at age, the study was broadly diverse from the age of the children from under 3 months to over 6 months of age, gestational ages of 35 weeks and above, gender, weight, and racial or ethnic group were broadly represented, and hemisphere of residence was also represented. So pretty broad study, very nicely done. And here are the hazard ratios for medically attended disease and hospitalizations. And you can see that for hospitalizations, medically attended RSV associated with lower respiratory tract infections. You can see that Nirsevimab had a very good profile relative to placebo over time, and the effects were long lasting. And that I think is a really important thing, because the other important issue is that it does appear to last at least here, if you look at this slide, you're talking about at least 5 months, and some think that this could go out as long as 6 months. So that's a pretty broad coverage. Now, if you look at outcomes such as medically attended, RSV associated lower respiratory tract infection, medically attended lower respiratory tract infection of any cause, and hospitalization for respiratory infection, you see that the efficacy is very good, anywhere from, well, for any cause is lower, obviously it's for 42%, but if you look at RSV, lower respiratory tract disease, it goes up to 77%. And the number needed to treat, I think, is really important, and this will be considered in the coming year. For number needed to treat ranges from 12 to 57 to avoid either lower respiratory tract infection, all the way up to 57 number needed to treat to avoid hospitalization. So that's really important, because we know that RSV is the second most common cause of hospitalization of children under 2 years of age in this country. And especially in developing settings where children are not diagnosed, we know that in some pilot studies, RSV turns out to be, other than influenza, a major cause of morbidity and mortality in children in the developing world as well. Here you see subgroup analyses by hemisphere, age at randomization, sex, race, weight, and gestational age. And for most of these metrics, the confidence intervals are reasonably tight, but they actually show relative risk ratios reductions that are favorable for just about every category. And you can see in particular for the young children, there's still, it's not as good as for those over 3 months of age, but still the confidence intervals are wide, but you do see almost a 60% relative risk reduction there in incidence of medically attended lower respiratory tract infections. And then I want to end just by saying that we have had a very chaotic 2 years with RSV. I published with my colleagues at UCSF and University of my colleagues at the New Zealand Public Health Department comparisons of Northern Hemisphere versus Southern Hemisphere RSV trends. And what we found is that because they're 6 months off in their seasonal cycle, our trends in Southern Hemisphere were mirrored. So when we saw reductions, they saw reductions 6 months before we did. And what you're seeing here is through April 2021, we did see a very chaotic year with rates of RSV going up in April, which is very unusual, not only in percent positive samples, but in absolute numbers of detections by PCR or by antigen tests. And you can see here, again, for the same period of time, we saw by region of the US, all regions experienced increases, but as you can see, they were all very idiosyncratic. So for example, in the Northeast, you saw bouncing, rates that were just jumping up all over the place throughout the entire year, whereas here in the Western United States, we did see increases in the middle of the year, in the winter, and then we saw an increase in the springtime. So we don't really know exactly what's going to happen next regarding RSV, but my sense is this coming year, things are maybe likely to stabilize, and we're going to see flu and RSV again, and we're hoping that in the coming year, we will see RSV, not only monoclonal antibodies, but potentially vaccines, at least for pregnant women at this point, until we can see better data on vaccines for children. So with that, I will stop, and thank you so much for your attention.
Thank you, Dr. Maldonado, so much. We have a few questions, and I'm going to start with the last one just because we were already on the topic of RSV. Dr. Sahar is asking, are the new antibodies for RSV being compared to Synagis as well as placebo?
No, the company Synagis was, it's all going to be historical comparisons. The company was acquired by another company, a Swiss company, and they are currently not participating in clinical trials.
Okay, and we'll go back to the initial question. Dr. McKenzie is asking, are wastewater surveillance systems being used to monitor viruses other than COVID?
Yeah, absolutely. In fact, I don't know that other places in the country are doing this, but one of my colleagues and I who worked on polio surveillance in Africa for many years. So her name is Allie Bohm. She's a civil engineer. She's a water engineer here in the engineering school. She and I worked together for 20 years doing polio surveillance from wastewater in sub-Saharan Africa and Eastern Africa. And she is now she has set up, as of last year, set up a very nice wastewater surveillance system here at Stanford, and also was able to acquire funds to do that for the entire San Francisco Bay Area. And so if you want to see those data, they are at wbe.stanford.edu, and you can see real-time surveillance data for not only Stanford University, but for all areas around the Bay Area. By the way, we're seeing an increase. She has actually tested influenza and RSV and can detect influenza and RSV, because remember, not to get into too much gory detail here, but sewage systems collect water from sinks, not just toilets, but sinks as well. So when people are brushing their teeth, et cetera, you will get some influenza and RSV RNA, and she is able to detect. Now, obviously, we don't know how accurate that is, but she has been able to track flu and RSV here at Stanford, and it seems to track well with what we're seeing in terms of reported cases. So I don't know if people are doing that around the country, but we certainly are doing that here for what it's worth. I think it's really helpful to have a little bit of an understanding of what might be coming.
Mm-hmm. So a few more, thank you so much for that response. And then a few more questions. Dr. Sahar is asking, I know you didn't speak directly about dengue vax, but will that be recommended for travel to those countries you mentioned, or just living there? For what duration of travel would it be worthwhile?
Yeah, I think you should look at the recommendations. They're pretty, unfortunately, they're a bit complicated. I worked with dengue, and I mean, obviously, Desiree Lebeau from my division is a dengue expert. I am no dengue expert, but I did work in the Philippines when they had a problem with their Dengvaxia, before people understood well that Dengvaxia does not do well when people have not had a previous infection. Not to go into too much detail, but there are 4 dengue serotypes, and with your first, and they don't provide cross protection, so you could potentially get infected with all 4. If you get one dengue infection, it tends to be mild, but if you get a second infection from another serotype, you have a reasonable risk of developing more severe disease, including dengue, hemorrhagic fever, and even death. Although that's rare, it can happen. And so it turns out that the vaccine acts like the first infection. So if you have a child who's never been vaccinated and never been infected, they get vaccinated, that when they get to see a real dengue virus, a wild type virus, that acts like their second infection, and those children can be at risk for dengue hemorrhagic fever. And so it is recommended right now by the FDA and CDC that you only give Dengvaxia to children who have previous serologic evidence of a dengue vaccine. So they have to have baseline positive dengue antibodies before they can get the vaccine. Now, that's complicated because that means you have to give a child a blood test to look for evidence of antibodies, which we never like to recommend because it's hard to do. But in this case, it could be preventing serious infection. And so we generally recommend dengue vaccines primarily for children who are going to be living in endemic areas. And in the US, that's primarily non-mainland American children, for example, those living in Puerto Rico, Guam, the US Virgin Islands, where the case rates are higher. And those require a blood test to document antibody before. So if somebody is planning to travel, it really depends on the duration of travel and where they're going to go. So I would check with the ACIP and the AAP guidelines. Those just, by the way, were published just in the last month.
Thank you, Dr. Maldonado. Do you have a time for a couple more questions to stay on?
I do have another meeting right now, but I could take one more question.
One more question. Okay, so Dr. Kennedy is asking, in the demographic differences for influenza vaccination, especially with respect to catch-up, how much of this difference reflects vaccine hesitancy? Vaccination efforts for the EUA COVID vaccines in approved pediatric populations is less than needed or expected.
We don't really know the answer to that question, but we are concerned about it. That's one of the reasons for the campaign. Obviously, what happened in 2020 was really truly just because of the impact we think of the pandemic and people's inability to get in to see their primary providers. And you see the impact was primarily in public clinics and federally qualified health centers. So it isn't clear, but we are starting to hear that there are some hesitance. There is some hesitance just for around vaccines in general. So we do worry a bit about that, but we don't think that's the major reason. And the reason is that you see that the vaccine for children orders and I didn't put this data in, but the private orders for private insurance companies are back to normal. So hopefully we can overcome some of that hesitancy.
Thank you so much. I know we don't have any more time, but I will send an email with the last question from Dr. Cap to you and try to get that response. And as a pediatric nephrologist, I very much appreciate this talk, and it's very important for chronic kidney disease, nephrotic syndrome, immunosuppressed patients, as well as for the general population. And thank you so much. And we also have a big thanks from the audience. Thank you so much, Dr. Maldonado.
Thank you.
And we will see you next week, obviously.
Yeah, see you next week.
Thank
Have a
you.
good weekend, everybody. Take care.
Thank you so much, everyone. Yeah.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.